Top Med Talk. Hello, welcome to Top Med Talk. I'm Andy Cumpstey and I'm here at the EBPOM World Congress here in London again at the British Library, our new venue. And I'm delighted to be joined by Dr. John Whittle, who's a familiar voice to many on the podcast, but we've got lots of exciting things to cover here. What have you been up to recently then, John?
So, currently I am an Associate Professor of Perioperative Medicine at UCL in the Centre for Perioperative Medicine. In that role for about a year now. We've got a small laboratory there, the Human Physiology and Performance Laboratory, and we engaged in some translational research trying to unpick some of the mechanisms of postoperative morbidity. Clinically, I still work at University College Hospitals, so I'm clinical lead for perioperative critical care there, and also rehabilitation and pre-optimization. So I split my clinical practice between those leadership roles and also some critical care and anaesthesia as a hobby.
And I've got to ask, what do you do in your free time?
Look after my 3 exceedingly young children. So I've got a 3-month-old that adds to the zoo at home. So
You're busy, aren't you?
So free time is not a thing.
Well, I'm very grateful you've given up some of your precious time to come and join us here on Top Med Talk here at EBPOM. I mean, there's a whole wealth of things we could dive into there and talk about in more detail. But I'm really, really intrigued by a concept which, I don't know if you've really coined the term, but you're the person that's definitely explained it best to me in the past, but this metabolic flexibility, inflexibility topic and what that might mean to other people. But before we get into that maybe in too much detail, let's take a step back and put it into context. So where does this work fit into a typical perioperative medicine sort of space?
So the work's relevant across the board in terms of preoperative care, optimization, immediate post-operative care, and probably post-discharge, though I haven't really looked into that side. I definitely have not coined the term metabolic flexibility or metabolic inflexibility before anyone writes into the podcast, but I think probably I'm one of the first people in the periop space to be really focusing on it as a driver or a potential mechanism for the development of post-operative complications.
And what do they mean, those terms?
Yeah, metabolic flexibility is the ability to appropriately select and upregulate substrate in response to metabolic demand. Metabolic inflexibility is the inability to do that. Now, if you think about us a little bit like being hybrid cars, this is very simplified, obviously, but your hybrid car will have petrol and an electric motor and use both fuel sources. And it may work in entirely petrol, it may work in a bit of both, or it may work entirely electric. And in general, that depends on the demand that you're putting upon the car. So if you put your foot on the accelerator, you go straight to petrol. If you're kind of somewhere in between, you're somewhere in between. And if you're just cruising along at low speeds through the traffic, you're on electric. And in the analogy, electric is fat and petrol is carbohydrate, glucose. So broadly, the population that are coming for surgery are changing. So we're getting older patients, we're getting deconditioned patients, we are getting increasingly comorbid patients, and though amongst those comorbidities are overweight, obesity. And broadly speaking, there's something called the metabolic syndrome, which will be well known. It's not exactly the same as metabolic inflexibility, although people with a metabolic syndrome will almost invariably be metabolically inflexible. Metabolic syndrome, about 40% of the patients age 65 and over now presenting for surgery will be diagnosed with metabolic syndrome. That can include hypertension, increased BMI, dyslipidemia, and, if not strictly diabetes, certainly pre-diabetic along the way.
As you mentioned, you hadn't looked at this in discharge yet, but in terms of screening and risk stratification, you have been looking at that. Now, again, for the benefit of our listeners at home listening to this, we've got the answer for this, haven't we? We use CPET. We've talked about that a lot, and we've got other 6-minute walk tests and other sort of dynamic scores of preoperative screening. Where does metabolic flexibility fit into that sort of space?
Right. So I think that's nail on the head territory, isn't it? So I think let's take a real step back. And if we say, in terms of risk prediction, we look at ways that we predict risk before surgery, the most common way that people around the world would be using various risk assessment tools, risk tools. And these risk tools incorporate various demographic details, various clinical details about medical history. If they're particularly advanced, they might include some biochemical or blood-based, laboratory-based biomarkers predictive of risk. And in general, they do an okay job of saying, X% risk of Y complication. The difficulty is that you could take, this is kind of the argument for CPET, I guess. You could take two 53-year-olds with the same medical history, so diabetes, hypertension, and dyslipidemia, but having the same surgery. And you could probably come out with a similar risk based on an epidemiological label. But it tells you nothing about that patient's individual physiological response to the stress of surgery. And so, of course, CPET has evolved over the last 10, 15 years as an attempt to overcome that and put some numbers and granularity onto the physiological state of the patient. So CPET cardiopulmonary exercise testing for non-regular lip listeners. But this is where it starts getting interesting for me. The question is why? So it's well established that physiology, and I mean exercise physiology, is a very good predictor of whether someone is going to develop a complication, morbidity after surgery, or even die after surgery, and across multiple surgical types. And that relationship stands. We looked at our own local data at UCL, published this year in PLOS Digital Medicine and Anaesthesia, Analgesia, if you want to take a look.
We can definitely put those, and we'll get the links, put them in the show notes for people to see afterwards.
And what we first described was absolutely, if you look at machine learning models we used of predicting morbidity, if you incorporate physiological measures, you can, number one, optimize the model, and number two, actually just predict morbidity even without knowing anything about the patient. Still don't answer why, it just says there's a relationship. So the traditional explanation for why CPET or an exercise test, and just to remind people who aren't CPET active, an exercise test normally includes an increasing ramp of work or workload over a 10, 15-minute period. The traditional answer is, well, that increasing metabolic demand of increasing work simulates in some way the increased metabolic demand after surgery. And the reason that it's predictive is because in order to meet that increasing metabolic demand, you have to increase your oxygen delivery to the respiring tissues. That's a marker of cardiac health. And those increases in cardiac output, oxygen delivery, are why CPET is predictive, which is great. And it's probably true for some patients. But the early postoperative period, in terms of metabolic demand, is absolutely nothing like a maximal exercise test in terms of intensity, in terms of required oxygen consumption, unless things are going extremely wrong for you. So most of our patients aren't experiencing systemic sepsis when they come and get on a bike. So there's probably something that's else about the exercise test. And there's a bunch of things that could interact from an exercise test. And one of those happens to be metabolic flexibility, i.e. your ability to appropriately select fuel.
So I'm just going to come back to I think I really like the electric car analogy at that point. So when you say your ability to appropriately select a fuel, I guess a bit like the car analogy, your ability to appropriate select almost gives some volition over it. It's just not that this is it's an entirely automatic response that no one's even aware is happening. That the car is switching in between petrol and electricity demands on its own algorithm, on its own.
Correct. So one of the arguments about CPET is actually it's a good reflection of your body's ability to perform allostasis, which is appropriate change in your physiology based on demand. And it happens that oxygen delivery is one component of that.
Yeah.
But also, absolutely, there are signals, your sympathetic nervous system ramps up, so there's changes in autonomic demand, and there's a whole load of other research about that, which we won't dive into today. In the patients that I mentioned previously, these patients with metabolic syndrome, we'll take them as a good example of a sort of crystallized, well-defined population. What do we know about these patients? We know that they tend to have something called insulin resistance. So And that insulin resistance tends to act in two ways. It tends to, and so what we're talking about here is hormonal changes, changes in the regulatory hormones around how you use fuel, what fuels you select, and how you respond to stress. And what patients with insulin resistance are unable to do is, number one, appropriately use glucose when it's needed, so their maximal carbohydrate usage will be reduced. And number two, actually, via a bunch of mechanisms that we don't need to go into now, they're also more likely to be reliant on glucose at lower metabolic demands. So you almost get into this sort of catch-22 situation. And why is that important? Well, a bunch of reasons. So number one, as we all know, fat has more calories per gram than carbohydrate. So as a fuel source, there is a higher oxygen investment to get those calories out, that ATP out. But once you've invested it, you've got a more efficient source. Number two, we have a pretty abundant store of it. Most of us have a whole bunch of fat. Even people with single digit body fat will have 20, 30 days worth of fuel stored on them. And of course, higher the digits, the more you have. But there's a massive problem there if you've got all this fat and you're unable to access it. So other reasons why metabolic inflexibility, just going away from any exercise testing or so on, may be important is you can't access the fuel sources that you actually have at hand. And if we're saying you've got increased metabolic demand, with glycogen, which is the main way of storing glucose, is a finite source. So, we store it in our liver, we store it in our muscles. We really only have, if replete, up to 2,000, 2,500 calories worth of glycogen stored. So what we're probably, and this is all hypothesis, but also, demonstrated widely in the wider metabolic literature, what we probably have here is, again, this vicious circle of a limited fuel source, which we can't use as efficiently as we'd like. And then you add in the perioperative period, and you say, well, what do we do to patients in the perioperative period? We starve them preoperatively. So we make, if they're already glucose reliant, we make them use up their glycogen even before we subject them to a metabolic demand. We starve them postoperatively, 2, 3, 4 days, without fuel after colorectal surgery. Again, if you're inefficient at accessing your own fuel sources, there's a potential problem. And there's a bunch of other things about metabolic inflexibility which are probably important. So what else do we know about people who are overweight, metabolic inflexible? We know that their immune inflammatory status is different from people who aren't. There's a whole load of interesting signaling molecules called adipokines, myokines, and these are signaling molecules which are akin to cytokines that can prime your body to respond in different ways to immune inflammatory stimuluses, and of course surgery is a massive one. So you could have, as a result of metabolic inflexibility, a dysregulated immune response to surgery as well. I think these are the two main things. The last observation, going back to the CPET at the start of all this, is this observation or this mantra about oxygen delivery and why patients with low aerobic fitness do poorly. So at medical school, we all learned that the limiting factor in maximal exercise is your heart, the ability of the heart to pump oxygen to the respiring tissues. And unfortunately, that may not be the case in our patient population. There's a bunch of very elegant experiments that have been performed. A concept called simorphosis, where if you take a muscle biopsy from a patient who is deconditioned, or a muscle biopsy from an elite athlete, and you perform something called respirometry, where you put it in a routine and you look at the maximum amount of oxygen that sample of muscle can use, and you scale it up per kilo, or how you might for a whole body exercise test, and you compare it with the whole body's ability to use oxygen during an exercise test. What you find in an athlete is that absolutely there is a maximal oxygen consumption in muscle above which the whole body VO2 max, maximum oxygen consumption, does not change. And that implies that the issue is delivery of oxygen to the tissue, because no matter how efficient your cells are, there's a point above which you can't deliver any more oxygen to the tissues, no matter how efficient your cells are, and that's your VO2 max. However, below these elite and highly trained individuals, there's a linear relationship between your peripheral ability to use oxygen and your whole body ability to use oxygen. So this suggests that in those individuals, the limitation is peripheral. It's at the cellular level.
Yeah.
And why is that important? Well, because actually it's quite intuitive when you think about it. The heart is the servant of the cell. The cell demand goes up, the heart increases its demand to meet it, and rarely, except in patients who have heart failure or other such things, does the heart fail to provide enough delivery. There's a whole load of other complicating features, but broadly that's true. So I think if you look at metabolic inflexibility as a candidate mechanism for postoperative morbidity, you start coming up with a whole bunch of interesting trailheads, which are very incompletely explored. But broadly, it would be, as I say, substrate utilization, availability, and efficiency in the perioperative period, just very broadly. It would be immune inflammatory priming, and it would be mitochondrial efficiency.
So we'll come back to those three in just a second, but I think just to, again, zoom out slightly, we're looking at this in a perioperative context, but this metabolic flexibility, metabolic inflexibility terminology topic, it applies throughout the whole of health, doesn't it? It's not just in a periop surgical context, but, the extremevorous work, looking at altitude, you see the same thing in Sherpas and lowlanders going to altitude, and their metabolic changes are driving a lot of their performance, and the Sherpas run past you at 5,000 meters carrying their houses on their back and you're out of breath, struggling to keep up. And all the things you've talked about are exactly the same in that context. You see the same in critical care patients, you see the same in, as you said, athletes, marathon runners. So although it can sound like quite a complicated, complex topic, actually it's pretty fundamental to our physiology throughout everything we're doing. We just maybe don't appreciate it enough.
I think that's exactly right. So this is why I love physiology, right? I mean, it is ultimately, surgery is one example of the interaction between human physiology and often dysregulated human physiology because of the population that we deal with metabolic stressors. Everything else you've just described are different examples in human beings of physiology interacting with challenge. And then I think in medicine, we often have it backwards. We are very keen on the diagnostic label of whatever it is, hypertension or whatever, but we are less interested in the physiological consequence. Ultimately, the physiological consequence is, number one, the individual patient experiences, and number two, the driver of any of the complications associated with that. I think broadly, metabolic flexibility and inflexibility actually has, even in the popular literature, in the news, on YouTube and TikTok, has been gaining increasing interest. You see it all around. You see people like Peter Attia talking about it. You see the glucose goddess talking about glucose usage and how to adjust your eating so you don't spike your glucose. And it's a slightly different thing, but
And it's not as binary as flexible, inflexible, is it? We're talking about a spectrum here where some people are exceptionally capable at making that switch. Some people are not quite as capable, can still do it, and some people really struggle. I guess it's a spectrum of like all these
Absolutely.
things.
It's absolutely a spectrum. What you will see in the most flexible people, we'll talk about an exercise test again, is that at rest in a starved or non-fed state, we should be using fat as our predominant fuel source. A little bit of glucose glycolysis happens all the time. Aerobic glycolysis is always occurring. So there's a bit of anaerobic glycolysis. That's why we have lactate, even at rest. And as you increase the intensity of the exercise, the fat burning lipolysis increases to a maximal amount. It's called fat max. Athletes are very interested in this, particularly endurance athletes, in terms of knowing where this is so they can be efficient for long periods of time. And in the background, an athlete's glucose usage will go up almost linearly to a maximal rate. And above that, you start going into other fuel sources.
And how easy is it to measure how flexible or inflexible someone is metabolically?
So there's loads of ways of doing it. There's biochemical ways. If you're a diabetologist and endocrinologist, you might be doing glucose tolerance tests. You might be doing glucose clamps, all these sorts of... Actually, glucose clamps are quite a difficult and specialist thing to do. It's hard to generalize. You can measure insulin and glucose in the blood. You can get a homeostatic model of insulin, for example. Or you can do an exercise test. And again, this is derived. This is not actually measuring at the cellular level what your cells are using. But broadly speaking, carbohydrates and fats have different amount of carbon dioxide. This is the basis of the respiratory exchange ratio. When you metabolize one or you metabolize another, different amounts breathed out, you can measure that and you can infer what fuel is being used at any given point. And so there's a bunch of equations that are well described that you can use in an exercise test to derive what fuel is being used. You can plot this as what's called the metabolic crossover plot, and you can see in visual form what people are using.
And how far are we off being able to use this in perioperative practice? So, I mean, you and I have both done hundreds of CPET tests over the years. I totally get, we can see on there someone's RER changing, what's the CO2 change. We can predict or estimate from there how flexible we think they are. I'm fully on board that many of us can walk into our pre-op room, take one look at an obese patient in front of us and presume that patient may not be as flexible as somebody else. But how far are we off them being able to take that information and materially change what we do for the patient and then how that affects their outcomes?
So really close and really far. So, in terms of the peri-op literature, specifically using exercise testing to predict metabolic flexibility and outcomes, I'm only aware of one paper that has demonstrated that relationship, and that's the one we published earlier this year. So would I recommend that people go and start doing this in their CPET clinics now? No, I wouldn't. I think, there's standard further research required. But number one, it's very easy to do. So myself and colleagues elsewhere at Duke and so on have the algorithm, plumbed directly. You can plumb it directly into your readout. If you've got the right CPET system, you can see it. You can eyeball it. You can put numbers to it, etc., etc. In terms of outcomes and observational studies, that study I mentioned that we published this year is retrospective. It's looking back over our CPET database. We just finished recruiting to a study called POM-MP, Perioperative Medicine Metabolic Profiling, which is a prospective study. It's only 105 patients, but we have extremely intensively looked at their metabolism over the period. So we've done preoperative CPET, preoperative body composition. We've taken their bloods. We're looking at mitochondrial function in different cells. We've longitudinally followed their oxygen and fuel usage over the early postoperative period, changes in their body composition, and obviously link that to morbidity. So hopefully in the next 6 to 12 months, we'll have now a prospective study, albeit small, which hopefully will then lead to further, maybe wider scale looks at this as a potential mediator. I think it's probably a no-brainer that it is a mediator, but, cut-offs, those sorts of things, they don't exist yet. What do we do about it, was your other question. I think probably there's some things that we can do now, and there's some things that we might do in the future. What can we do now? I think recognizing it as a potential mediator and not dismissing those patients who we see every day who are likely to be metabolically inflexible or have satisfy the criteria for metabolic syndrome even. And just to be clear, you don't have to have metabolic syndrome to be metabolically inflexible. And appropriately planning their perioperative care. So maybe you might think about avoiding the dexamethasone at the start of the case. Certainly, this is level 1 anecdote, but we certainly see in these patients a nice little spike in their blood glucose early postoperatively. You might want to think about really focusing on your ERS pathway. If they're using sugar as a fuel, give them some sugar. Make sure that carbohydrate loading drink's there. What about that early postoperative feeding? Should we not starve them for a prolonged period? Should we actually follow the current evidence-based guidance around feeding? So I think, good perioperative care is number one. Rehabilitation? Absolutely. So again, there's plenty of evidence in the wider metabolic literature, the wider sports and exercise science literature, that exercise can alter your metabolic flexibility. Extremely tiny study that we published as a research letter the last couple of months from Duke where we subjected 10 patients to the high-intensity interval training program, the structured responsive exercise training program described from Southampton. And the bottom line is, in 6 weeks, in these deconditioned elderly patients that we recruited, we were able to switch their metabolic flexibility derived from CPET. And we also, very interestingly, and this is where I think we could start getting really cool, saw changes in the ability of immune cells to use fat as a fuel. And why is that important? Well, because actually the metabolic inflexibility or immunometabolism is a massively expanding space in immunology and has a huge impact on responses to various things like, for example, cancer or infection or stamps, pathogen-associated metabolic patterns, damage-associated metabolic patterns, the sort of things you see around surgery. So again, I think there's a whole load of potential things there, and then there's the questions, what do you do? Are we going to give patients metformin preoperatively? Are we going to recommend intermittent fasting? Are we going to give them ketones? I don't know. I can't put my money on any of those, but I think, first of all, recognize, and then, you can counsel, you can do some preoperative management, which already fits within best practice. And then let's see.
Fantastic. Exciting times ahead. A fascinating topic. Thank you for explaining it so well. And I think some really strong key messages in there that we can all take away and think about our practice. But I look forward to hopefully you coming back in the future and giving us some more exciting results.
Absolutely. Look forward to it. Thanks.
Thanks, John. As always, you can hear us online on our website. You'll find this podcast on your podcaster of choice. You'll find us all on social media too. Top Med Talk's now on YouTube. Give us a thumbs up, hit subscribe. We're on LinkedIn, X or Twitter, Blue Sky, Facebook. We're on all of them. So please look us up, give us your comments, give us your feedback, and we'll look forward to hearing you here soon.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.